You're listening to the Move to Value podcast, powered by Chess Health Solutions. The Move to Value podcast is dedicated to helping healthcare providers understand and make the transition into value-based care. We do this through conversations and the sharing of innovative ideas with practitioners, experts, and leaders throughout the healthcare industry. Our mission is to sustainably transform the healthcare experience for the patient, provider, and care team by cultivating a value-oriented, compassionate, and health-aligned community. In today's episode, we continue our conversation with the American Heart Association's Melanie Phelps, who is integral in the recently published study on the benefit of accountable care organizations. The findings support that managed care not only improves outcomes for the medically complex patient, but also benefits every patient, family caregiver, provider, and healthcare team member.
Melanie Phelps, welcome back to the Move to Value podcast.
Thank you.
So let's try to pick up where we finished last time, Melanie. And I wanted to go back to sort of the heart of your research in the medically complex patient. So we know these folks require higher touch and really need coordinated care. And wanted to talk about why it's crucial for the American Heart Association to understand and advocate for better models of care for this patient population. And then after that, we'll follow up on sort of how we can work together to do that.
Yeah, so medically complex patients are, of course, more complex and more costly. They require a lot more services, and the burden of navigating a fragmented fee-for-service system adds to their already very stressful lives. And the chances of things falling through the cracks or delayed care is pretty high in a pure fee-for-service system. The ACO provides those extra layers of support, communication, and enhanced access that really do lead to better outcomes, reduce stress on the patient and their caregivers, which is pretty important. We also believe they are more likely to get the most up-to-date care under these arrangements because the incentive to do better is there, and that is not there in the case of fee-for-service. So we all know that there is a pretty significant lag between new innovations and evidence-based solutions and adoption or implementation in reality. And we see ACOs as a vehicle for expediting adoption of those.
Absolutely.
The other piece on medically complex patients, why we wanted to focus on those is when talking to other patient and consumer advocacy organizations, which is a key target audience of this study, there was a lot of apathy and even skepticism about ACOs. Okay, they're not involved in the advocacy, they're not steeped in the details, and they are very suspicious of ACOs, of value-based care. They're thinking there's a lot of stinting going on. They think that they're being, medically complex patients are being denied care and being kicked out of ACOs. And that certainly was not my experience when I worked with the ACOs in North Carolina. So one of the reasons we focused on medically complex patients was to be able to say, okay, are they getting the care that they need? What do they have to say about it? And that's why. I mean, these are the people that really need the extra care and support. And the results really showed that they were getting much better care and support, which should be important to everybody.
Yes, absolutely. That's interesting. I guess I never would have thought about that kind of skepticism from consumer advocacy groups around value-based care. And certainly my experience has been the exact opposite. Is the ACO model is an ideal model to have those patients in because you have a sustainable path to provide these wraparound services to both the provider and the patient and their families. I can think of multiple instances where these, like in our next gen days and our ACO reach day nursing facility waiver as an example. And while that is great for patients, I think we've had more comments from caregivers and family members about the benefits of that program than we have from patients themselves. So it's really interesting that it's another layer of skepticism that we need to break through. So going a little bit further then, so how can ACOs, provider groups, working inside ACOs, how do we get past that skepticism barrier, so to speak? How can we work together with organizations like the American Heart Association to promote ACOs and the benefits for patients, families, and health team providers?
So one of our challenges, and it was a pretty significant challenge, was the fact that to recruit study participants, particularly the patient and caregivers, how do you do that when somebody doesn't even know what an ACO is or that they're assigned to an ACO?
Right.
I mean, there are a lot of regulatory requirements around that, and they're not particularly helpful to meaningful communication and meaningful understanding.
Right.
So how can patient and consumer advocacy organizations help communicate the benefits of this model and similar models? And it's through research like this that comes from a neutral patient advocacy group that folks can give or use to help communicate the benefits of in a way that's relatable to folks. So often we talk about ACOs from the provider perspective. Well, providers get paid differently to do that, and that's not what's going to resonate with patients or their caregivers or their advocates. What does it mean for them? And until we really do a better job of doing that, I don't think we're going to have a huge cry from patients and consumers and community advocates. And it's a shame because people should be demanding this kind of care. Yes. Right? Not running from it or not ignoring it. We should be working together to improve a very good and solid model. So that's
I think you're right. We want to create a stampede almost for patients demanding access to these kinds of programs. But you're right, folks don't know what they are, and they don't know, unfortunately, they don't know when they're in one. They don't know when they're not in one. It's just not obvious. And the communication options sometimes are onerous and restrictive and don't allow sort of the free flow of information back and forth between the providers that are in these models and the patients. So that's a real challenge.
You guys are restricted in what you can communicate.
Right.
We're not.
You're not. Yeah, you're right.
So we are a huge untapped resource, and we being the patient and community and consumer advocacy community. But most of us, there's only a handful of us that are engaging in these policy discussions, and so we really need to grow that table.
So, Melanie, given the American Heart Association's clear role in guiding heart health recommendations, does this study suggest that ACOs are a model that should be used to promote these preventive health recommendations more widely for all patients, first of all, but then particularly as it relates to those who have cardiovascular disease?
Yeah, simple answer is yes. I think we'd say all patients, including those with CVD or cerebrovascular conditions, should reap the benefits of ACO and similar models. So, but it shouldn't just be patients with CVD or cerebrovascular issues. All patients, especially those medically complex patients, will reap the benefits of these models.
Yeah, I think what we have to be mindful of, I've been thinking about this a lot lately myself, is that we need to make sure that the value-based care movement, if you will, doesn't get mired down in becoming a chronic disease management solution only, right? How do we leverage the infrastructure and the data, the tools, the technology we have to prevent chronic disease, right? I think the fee-for-service world has just turned into a sick care system, not a healthcare system. And we need to be mindful that we don't allow the value-based care movement to become that same, to be captured by that same mindset, if you will. Well, as we start to round home here, what do you hope that health systems, policymakers, and other patient advocacy organizations, which you've mentioned, take away from this research, and how can the association help drive change based on your findings in this study?
So I hope that all the groups that you mentioned will have a better understanding of what ACOs do, what they are, what they mean to those on the front lines of receiving and providing care. That's the patients, their family caregivers, and all the members of the health care team, and how it improves the care they receive, their quality of life, how it saves money by catching things early and avoiding costly trips to the ED and duplicative services, and of course its focus on prevention. And finally, again, we really need to see more people, patients, caregivers, and healthcare team members in these arrangements.
Yeah. So what are your next steps for the American Heart Association? More research, further exploration of how ACOs can impact cardiovascular and other health outcomes. Where do you see the Heart Association going next?
Yeah, so we don't currently have plans to explore the impact of cardiovascular outcomes, at least not to my knowledge. That would be a different section of AHA. That doesn't mean we won't. It just means that I don't think it's been discussed or has not been shared with me. And so what else is there? Well, there's an outline of a heart failure model that we published as part of our Value in Healthcare initiative back in 2020 with Duke Margolis.
Yes.
I've heard that there's some interest by the current administration in that, but we haven't been contacted directly about that. We do have a huge food as medicine initiative. It's called Healthcare by Food. We're putting millions of dollars into research on food as medicine. And there's, I think we might be exploring how food as medicine can be utilized in these models, how successfully it can be utilized in these models. And then regarding this research, we do hope to further engage and educate other patient and consumer advocacy groups, and then work with them and other stakeholders on elevating the patient-consumer voice in these models so that they can truly be person-centered, right? I mean, we talk a lot about person-centered care, but really the patient hasn't been part of those discussions. Right. How do we make that more integral at all levels of decision-making on value-based care?
Yeah, absolutely. So that's interesting. Food as medicine. There is a lot of interest, I know, today around what's called functional medicine, and a big emphasis on healthy foods, and it's just so important. And I know from my own lifestyle, it's challenging to sometimes know what to eat or how to prepare what to eat, but that's really good to hear that you're working on that. The last question I'll ask you, Melanie, is one I usually come to at the end of any interview, and that is, we've talked about a lot today, but is there anything that we've not covered today, or I've not asked you, that will be relevant to this conversation that you'd like to share with our audience?
I can think of two things. First of all, I think your listeners would be really interested to know that we conducted 29 semi-structured qualitative interviews with 31 individuals, and that means that 2 of the interviews included the patient and their caregiver spouse. That's how we got to 31.
Mm-hmm.
But we only were able to include in the data analysis 27. So 2 interviews with the patient, with individual patients had to be discarded because something was wrong with some of their responses that made me think they were not in an ACO. So after the conclusion of the interview, I was able to go and trace back through their PCP and their PCP practice, whether they were in an ACO or even some other primary care arrangement, and they were not. Okay, so how did that happen? And well, first of all, the giveaway, why I suspected they weren't in, well, there were 2 reasons. The first one, neither one was managed, right? And so all the other medically complex patients that I had interviewed, they were managed, and these 2 weren't. They also happened to be sisters, and they were also cousins of the care manager who was helping with recruitment, right? So we had to change. We had a lot of trouble getting patient and caregiver study participants. And so we had to change our research protocol. So instead of the healthcare organization getting a HIPAA authorization to give us contact information, we gave them a flyer that they could hand out to appropriate patients to call and, on their own asked to be part of the study. And there was a $100 Visa gift card that was assigned to it. Anyway, so we had this overzealous care manager was giving them out to friends and family. So yeah, so we had to regroup and change again. But it was very interesting that I could tell that they weren't in an ACO.
That is interesting.
I would not have expected that. The other issue that I think was really interesting is that, at the end of each interview, we asked, if they had any suggestions for improvement. And so the patients, for the most part, didn't have anything that was particularly helpful. We had one patient that said that they didn't like their primary care had inadequate parking. Another one didn't like their primary care, provider, but knew they needed to change. And then the only other suggestion for improvement was from the patients was that external providers who were not in the ACO, there was a little bit more difficulty communicating. No big surprise there, right?
Right.
So that was all we got from the patients. So then you go to the healthcare team members. And what was really remarkable is there was a cry for more education and communication about the benefits of these models, not only for their peers, but for patients as well. And they wanted more patients in these models. And one even lamented not being able to provide the same services to patients not assigned to the ACO. And then we did hear challenges with data sharing with external providers. I mean, not a surprise there, right?
Right.
There was also calls for multi-payer alignment because of all the different contracts and rules, and oversight and concerns about the ratchet effect over time of the benchmarks, right? That's being a problem. Yeah. And then finally, enhanced payment for primary care services was mentioned, and that didn't even come from the primary care docs.
Wow.
And I probably should let you know that as far as the care team members are concerned, I interviewed 4 primary care physicians, a specialty physician, a nurse practitioner, 4 nurse care managers, 2 community health workers, 2 social workers, and a pharmacist. So I had a pretty good, diverse makeup from sample. So
that's great.
So that was pretty interesting. I thought that was pretty interesting to capture that information.
Yes, it is. Well, Melanie, thank you so much for joining us today. It's been an intriguing conversation. I'm looking forward to hearing more from you, and thank you for joining us.
Thank you for having me.
This is the Move to Value podcast, powered by Chess Health Solutions. We hope you have enjoyed this episode. If you would like more information about this and other episodes, you can head over to movetovaluepodcast.com to check out all of the available resources. If you're interested in continuing to hear about value-based care and how it impacts you, you can sign up for our email notifications or subscribe to this podcast on your favorite podcasting platform. Also, we would love it if you would share the Move to Value podcast across your networks and leave a rating or review. Thanks for listening.